other manifestations, starting with fever. So the fever in patients with cancer is usually due to an infection. Sorry?
Yeah. I'll just close this.
Oh, okay. Like this?
Yes.
Thank you. But it's coming up again, so I don't know why. All right, we'll close it every time it comes up. All right, anyway, so fever. Why do patients with cancer have infections? Any idea? Immunity. Why is that? Why would their immunity be, you're saying immunocompromised, right? Any idea? So cancer itself is an immunosuppressed state. All right, so cancer itself, by definition, is an immunosuppressed state. And the reason for this, those patients would not have actually developed cancer if they were not immunosuppressed. The reason for this is that there are a lot of cells that become actually cancerous, and the immune system takes care of it. The immune system will target it and destroy it. But then, after a certain age, usually the age of 50, or a little later, that's when the immune system starts to wane, starts to weaken. That's why you see actually that the number of cancers in older patients are more than younger patients, as an idea. So what could it be due to? It could be due to anything, but most commonly, it will be a gram-negative sepsis, either by E. coli or the Pseudomonas. All right, and then there is actually a big section that is known as a paraneoplastic syndromes. And in this one, what you're going to be finding, actually, you're going to be finding distant effects of the tumor away from its site of origin. So this, presentation is not due to, a local kind of encroachment, local kind of compression, of the tumor on nearby tissue, or actually invasion of the tumor on nearby tissue. No, it is actually distant away from the tumor. And that is going to be unrelated to metastasis. That's another definition. The reason why, for example, I did not tell you that it will be due to a hormone that is being produced by the tumor cells, by a non-endocrine tumor cells, is because it could be hormone, it could be something else. It could be mucin, it could be growth factors, so on and so forth, that is going to be, giving rise to manifestations due to what is being made by the tumor cells away from the tumor itself. So why is it important? Because it could be actually one of the opening presentation, the opening salvo of someone with cancer. About, it happens in about 10 to 15% of cancer patients, and sometimes it is the first manifestation that you see in those patients. All right. So what are the most common syndromes that are known to be paraneoplastic syndrome? There's, the big chunk is the endocrinopathies. Then there are some skin lesions, coagulation abnormalities, and nerve and muscle bone changes. Skin lesions, you may see that actually, due to the effect of the growth factor on the skin, on the epidermis. And that has been shown actually in a lot of, the skin disorder, the complicated skin disorders, such as dermatomyositis. You see, for example, that the skin has actually undergone redness, undergone thickness, and that's due actually to the fact that the tumor cells, are elaborating a form of a growth factor that is going to be working on the epidermis, giving rise to this kind of presentation. Now, coagulation abnormalities, this is most likely is going to be, something that is related to, to activation of the coagulation cascade. For example, something related to actually the tissue factor that a tumor may interfere with, resulting in activation of the coagulation cascade. It could also be due to the making or to the elaboration of mucin by the tumor cells, especially with adenocarcinomas. For example, there is a very important actually coagulation abnormality syndrome or paraneoplastic syndrome associated with adenocarcinomas of the pancreas and of the colon. Those actually tumors that make mucin. Those patients are going to present with migratory thrombophlebitis. Migratory thrombophlebitis as a result of actually the mucin that is being made by the tumor cells. Nerve, muscle, and bone changes and pain, especially pain, bone pain, is one actually of the presentation that is known now to be associated with lung cancer, also due to the, to the making of the tumor cells of, factors that may actually be similar to osteoclast activating factor, or some of other factors that could be affecting the bone, the muscle, or the nerve. All right, so starting with endocrinopathies, this is actually a big section. There are many hormones that are being made by tumor cells that itself are not really endocrine cells. So, for example, small cell lung cancer, one of the most active, hormonally active or endocrine active tumors, make a lot of actually different hormones or hormone-like substance. It's not really the exact hormone. It is, something that actually that is similar to ACTH or to, to ADH and so on and so forth. And the result of that is going to be that this ACTH is going to work, or ACTH-like substance is going to work on the distant, organs, the distant targets of these hormones, resulting in a very, strange presentation. So, for example, with Cushing syndrome, where you start to see that the patient is starting to have hypertension, starting to actually, increase weight, and have a lot of fat tissue that is accumulating. The moon faces, starting to develop a hump on their back, and a central, obesity. That's our truncal obesity. That's actually due to the ACTH that is being made by small cell lung cancer, most commonly actually by small cell lung cancer. Hyponatremia, on the other hand, that's what you call delusional hyponatremia, as a result of the making of the tumor cells of the antidiuretic hormone. So the antidiuretic hormone will act actually on the collecting tubules of the kidney, and the result of that is going to be delusional hyponatremia. Where else would you where do you see it? In small cell lung cancer as well. So then there is the hypocalcemia, and that's due actually to the making of the calcitonin by tumor cells. So calcitonin, if you guys recall from the first year, calcitonin acts actually on the osteoclast, right? This is the only receptor that the osteoclast is having. It's what you call an emergency shut off, for the osteoclast by the calcitonin. So the calcitonin is going to knock down, if you will, the osteoclastic action. And as a result of that, you will start to see less calcium that is reaching the blood in those patients. Gynecomastia and the beta HCG, hormone, you see it with choriocarcinoma of the testis. And the most common, actually, the star of the paraneoplastic endocrinopathies is the hypercalcemia. Hypercalcemia that happens actually as a result of the making of the tumors of either of PTH, parathyroid hormone, or parathyroid hormone related peptide, or actually, by the release of what you call, osteoclast-like activating factor. At the end of the day, actually, both these two are working actually on the osteoclast. And the result of that is going to be more calcium reaching the blood, resulting in the presentation of the patient with hypercalcemia. So now you know why actually those patients with malignancy presents with hypercalcemia. They present with hypercalcemia as a result of one of those two, factors right here, either a PTH-related peptide or an osteoclast-like activating, factor such as IL-1 and others as well. All right, so now when it comes to diagnosis of neoplasia, all the morphologic methods that you're looking at here, whether it is the biopsy that is usually sent on an elective basis, the frozen section, which is usually sent during the operation itself, the fine needle aspiration cytology. This is instead of actually opening the patient up, and take a big cut of the tumor. Actually, you simply, probe the tumor with a fine needle. Then there is cytologic smears. That's when you lay down actually the cells that you got usually by the needle or by the biopsy. You take the biopsy and actually you make it, touch the surface of the glass slides. When you do that, you're going to be leaving actually some of those cells on the glass slide. If you take that glass slide and stain it, you're going to be looking at actually malignant cells. Or, immunohistochemistry. Everything that you're doing here, you're doing to establish a very important, concept, which is the concept of monoclonality. If you're looking morphologically, if you're doing immunohistochemical stain, if you're doing cytological preps, you're looking and trying to establish that all the cells look similar. That's actually the definition of monoclonality, right? That all the cells come from the same cell. They gave rise to the same cell. And that's exactly what you're going to be doing here. Now, that's not limited to this. There are other what we call ancillary kind of testing. So you may actually send this tumor, section to the cytogenetic lab, where they are going to look for a specific translocation. That itself actually is, a way to establish monoclonality. You may send it to the molecular lab to look for a specific, for example, specific point mutation or a specific deletion. Also, that means all the tumor cells carry actually this, point mutation or this deletion. Again, a way to establish monoclonality, and so on and so forth. So everything that you're doing when it comes to neoplasia, in the first instance, the most important reason is going to establish that all those tumor cells belong to or came from a single cell, okay? Then there are other things that you're going to be doing when you're looking at a slide. For example, you're going to be looking and trying to see if actually the sections that the surgeons have sent you are actually free of the tumor. This way you are going to ensure that there is no those irregular borders that we talked about that is known to be present with malignant tumors, right? With malignant tumors, you don't see the expansile-like growth, the growth by compression. You see growth by infiltration, if you recall from prior lectures. So, the surgeon want to know that actually he took out the whole tumor. And they do this actually by taking, what you call a large margin of resection that will go around the tumor, tumor infiltration, the tumor fronts actually, or the tumor, extension. Another thing that you may want to do that actually when you look at, at a section from a tumor. So molecular methods. Let's take actually a sample that's coming from a patient with let's see, with acute leukemia. The flow cytometry methods is going to look for special, cluster designation molecules on the surface of the white blood cells, what you call CD molecules. And you have to actually, what you are doing, when you send a sample to the molecular lab, you're again establishing that all those cells are going to be carrying, for example, the CD20, the CD10, because you want to be calling it, a B cell leukemia, okay? Or actually it's going to be carrying the CD34. That's going to be something that you see with acute, myeloblastic leukemia, and so on and so forth. So again, everything that you are doing is there actually for you to establish that what you are looking at is a monoclonal proliferation. Why? Because there are other proliferation that look like a tumor, that present like a mass, but they are not really tumors. The tumor-like presentation. An inflammation may give rise actually to a mass. So how could you differentiate an inflammation from a true neoplasm? That's actually by establishing monoclonality. So the inflammation will be polyclonal. So when you look at the CDs, for example, in those tumors, you will not be able to pinpoint a population that carries the CD10, the CD11, the CD20. No, you will carry a population that takes actually the CD10. Part of it is CD10, part of it is CD20, part of it is CD11, meaning it's coming from different sources. That's why you're calling it actually polyclonal, population of cells, which means it is not really truly neoplastic. If you look at an inflammation, mass, if you will, you're not going to be seeing that all the cells look the same. No, because you're going to see, different types of inflammatory cells that are coming from, from different, origins. So you will see the plasma cells, you're going to be seeing the lymphocytes, you're going to be seeing the neutrophils, right? So you're going to be seeing macrophages. You're going to be seeing a mix of cell as opposed to a monoclonal, population of cell coming from from one cell, and so on and so forth. The same exact thing with tumor markers. Why are you going to be doing a tumor marker? Let's say that all the tumors carry the S10, the S100, I'm sorry, the S100 in the case of a melanoma. Another actually way for you to establish monoclonality, because all of those cells carry this marker that is an establishment of monoclonality. So you're saying this is a monoclonal by the type of, the marker, for example. By the time of the marker, by the type of the immunohistochemistry, you will be able to label it as an epithelial tumor. You may be able to label it as a mesenchymal tumor if all the cells actually presenting with vimentin and desmin, for example. If all the cells are presenting with cytokeratin, then this is going to be an epithelial tumor. All the cells presenting with vimentin and desmin, that's going to be a mesenchymal tumor. So you're going to be establishing monoclonality, and also at the same time, you are going to be establishing the type of tumor that you have. Okay, so it's going to give you, several conclusions, right, from the examination of the sections at hand, of the sample at hand. But the most important one is going to be establishing this monoclonality, because that's really the base of the malignant neoplasm that you are dealing with. Okay. All right, so this is some of those immunohistochemical stains that you may use, to establish the monoclonality and to establish actually the type of tumor you're dealing with. So for example, when it comes to leukemias, you have the common leukocyte antigen, the CD45. You will see all the cells carrying the CD45. So in a way, actually, that's going to tell you that what you are dealing with is a leukemia. Then the next step will be actually to ask yourself, what type of leukemia am I dealing with? Is it a T-cell leukemia or is it a B-cell leukemia? So you guys probably know that or not yet, maybe not yet. For the T-cell leukemia, it is those actually CDs that are less than 10. So CD3, CD5, CD7, less than 10. For the B-cell leukemias, this is going to be the leukemias that carry the CDs that are more than 10. So the CD11, the CD20, the CD23, CD25, and so on and so forth. Then there is actually, am I dealing with a neuroendocrine tumor? There are some stains that are going to point you that way, including the S100 and the neuron-specific enolase, immunostain. Carcinomas, how do I know if I'm dealing actually with an epithelial tumors? Of course, the most important thing is going to be morphology. So when you look at a carcinoma, when you look at an epithelial malignant epithelial tumor, you're looking actually at a 3D dimensional, structure. So morphology is very important for you actually to reach a diagnosis of carcinoma. Then comes the supporting, test, such as the immunohistochemistry that is going to help you, cement your diagnosis. So in this case, you will see that the carcinomas will be positive for cytokeratin, for the epithelial membrane antigen, the EMA, and for the CEA. That's going to be more of a carcinoma. That does not mean that there will not be any mesenchymal markers that may carry this, but usually that is extremely rare. So you will see that those tests are not really 100% foolproof. So this is why at the end of the day, it's going to be actually really the eye of the pathologist looking at those slides and making this these assumptions, and then making these diagnoses, and at the same time trying to see any kind of support from the immunohistochemistry panels that they have done on those sections. Tumors of mesenchymal tissue, vimentin, could a carcinoma present with vimentin? Yes, that's rare, but it could actually present with vimentin, especially the poorly differentiated carcinomas. Muscle-derived, sarcomas, you will see that desmin is going to be there. Tumors of endothelial origin, you will see the factor 8. You do factor 8 stain, and that's actually a stain that is related to endothelial cells. So it will light up in the tumor cells that you're dealing with. Flow cytometry, this is where you are trying to establish actually the identity of a liquid tumor. You are trying to establish the monoclonality and the identity of a liquid tumor, of a blood tumor. Now you may use it actually for solid tumor, but using it for solid tumor is really rare. The reason for this is that the solid tumors, cells are really large, and for the cytometry aperture, the openings it is usually small. This maybe have This maybe is changing, as time comes by, but it is really very well established for leukemias and lymphomas, less so for solid tumors. There's the DNA probe analysis, in this way you are actually looking at a couple of things. For example, let's say that you're looking at a CML, at a chronic myelogenous leukemia. And with CML, you will see that there is a very, distinctive kind of translocation, the T922. Now, this you may actually be able to see with a simple cytogenetic analysis. You look at the chromosome, and you will be able to see that actually chromosome 9 and 22 have actually switched, genetic material. So you may see it with cytogenetic analysis. If that does not happen, and if you still have actually, clinical suspicion that this is a CML, then you will send those samples that you have to the molecular lab. And in the molecular lab, they will do a higher level of testing. In this case, it could be a PCR, because the PCR will give you actually, will tell you that you do have this kind of translocation, because it will look at the fusion gene, at the BCR-ABL. And it's going to pinpoint it for you. You may do another test known as FISH test, the fluorescent in situ hybridization, that is going to tell you the same actually thing. That's going to tell you that you do have this fusion gene that is present in this patient, that is going to actually confirm for you a diagnosis of chronic myelogenous leukemia. Now, there are other testing, because as time goes by, also more molecular techniques are being added actually to our arsenal, including next generation sequencing. Now, actually, you can sequence the whole genome of man in about, do you guys know how long it takes to sequence the genome? Could you do it in Riyadh? Could you sequence your own genome in Riyadh? Yes, you could. How long does it take? Do you know? About a day, actually. Usually like 3 to 4 hours, to get the whole answer. Now, I don't know who is brave amongst you who is going to do it. Personally, I will never dare to do such a thing. I'm afraid about what I'm going to find. This is a joke. I hope you understand it, So really, like, you will see that science have advanced so much. It has advanced far more than actually like the how to deal with the information that you're getting, And this is one example of that, it is available commercially. Many labs, could do it. And again, the question is, what will be your response? God forbid if you find something that, that is not good. All right, so we did talk about chromosomal analysis, also known as, cytogenetics. Now, how could also you establish, monoclonality? How about if you do actually electron microscopy? So instead of looking in the light microscope, lenses, and having magnification of, let's say, 500 by 10, you're looking at probably, 5,000 times. How about if you look at the slide and you are able to magnify, the slide, 100,000 times or more? And that's exactly what you see actually with electron microscopy. So in electron microscopy, you will be able to look at the subcellular structures. That is going to, for example, tell you that you may have tonofilaments. If the patient, if the sample you're dealing with is having tonofilament, this is what you see in epithelial tumors. So all the cells will be carrying tonofilaments. So what are you establishing in this case? Again, monoclonality, right? If all the cells, carry Weibel palade bodies, this is what you're going to be seeing in angiosarcomas. In a neurosecretory granule, this is what you're going to be seeing in neuroendocrine tumors, and so on and so forth. So again, this is another method to establish monoclonality, to actually go back and say that all these tumor cells are coming from this tumor, from this single cell. So that's one, establishing monoclonality. Two, actually establishing the the type of tumor you're dealing with, because it will point you one way or the other. All right, so this is it. Any question about this? Let's do that here. So then, yes.
After what the antigens?
Antigens.
That's like,
This one?
yes.
This one?
You have to know everyone.
No. This is just an example actually to show you. What I'm more interested in is the concept. The concept, of why you're doing this test. And the answer to that is monoclonality, exactly. So then.
For the same slide here, we cannot, it could be for both malignant and benign tumors.
No, this is not going to be in, because what you're going to see, you're right, actually, in a way, you should look for actually especially a mutation in benign tumors, you're right. But it will not go beyond that, actually. It will not go beyond that. Or at least it's not in practice actually to go beyond that when it comes to benign tumors. Okay, so all this workup is really for the malignant tumors, everything that you have seen here, whether it is the immunohistochemistry, whether it is the molecular methods. All right. Now, how would you differentiate then, a benign tumor versus malignant tumor? Again, you will see that there are, very solid features for that. And we do have actually a comprehensive, differential diagnosis, if you will, for benign tumors. So if you have seen a tumor that is growing slowly, that is minding its own business, and that is actually not invading, that is encapsulated, okay? Usually this is going to be more of a benign tumor. And then you have to actually reach the final diagnosis in this case. You cannot just leave it at the benign tumor. You have to know what tumor you're dealing with. And for that, actually, you may use some of the stains. Yes, I agree with that. But, like not to the point that you're trying to actually show, you're going to be doing anything beyond probably a single molecular test to look for the mutation that those tumors are going to have. And the mutation in this case is going to be a very simple mutation. Most of the time, it will be a simple mutation in the form of a point mutation, for example. And that's going to be, as opposed to what you see in malignant tumors, where you see a more complex kind of, mutation, and that's going to be translated phenotypically into a bland tumor, a tumor that does not really, that impress, if you will, in terms of morphology. So you will see all the tumor cells, have the same morphology, and they are of a low kind of grade, very low grade. This is one. Two, actually, you're not going to be seeing any kind of invasion, morphologically speaking. So, even though we have talked actually here about using morphology to establish monoclonality, but for the malignant tumors especially, you will see that those tumors, do have ability, because there is, and if you think about it, there is loss actually of the normal cellular mechanism. Those cells may actually attain different sizes, different shapes. This is why you have actually this, if you look at the anaplastic tumors. So, and the more, high grade of the tumor, the more likely that you're going to be actually getting a mixed kind of picture. Whereas for the most differentiated tumors, that is going to be the benign tumors, you're going to be looking at a very bland kind of, morphology or cytology. So the cells will not impress. They will be of a very low grade. Okay, this is one. The other thing that I received a question about this from you guys, and that was, do you apply the well-differentiated, the poorly differentiated, and the moderately differentiated to benign tumors? And the answer to that is no. Again, it is no. You apply those, this nomenclature only to malignant tumors. Why? Because benign tumors, by definitions, are the most well-differentiated tumor around. So, it does not apply to them at all. All right?
For the example of leukemia,
right.
So if we just examine the CDs, we will see only CD45.
No, you will see CD45 will tell you that so there is actually, when you're looking, it's the reason why I did not go through the fine details of this is because it's not really applied to medical school. But let's say that you're dealing with a tumor mass. One of the first things that you're going to establish first is what are you dealing with? Is it epithelial? Is it mesenchymal? Is it neuroendocrine? Is it melanomatous kind of, mass? And that's going to actually have different features. We know, for example, that epithelial tumors will be more cohesive than mesenchymal or actually, neuroendocrine or, the melanomatous tumors. This is number one. Yes, that's number one. Number two, you're going to actually try to support this assumption that you have made, that this is an epithelial tumor, or let's say that this is actually a leukemia. And the way to do it is that you go for what you call a main marker. In this case, it is the CD45. When CD45 is positive, it tells you you're dealing with a leukemic population. Then you go into, the next, level of testing, which is going to decide if this is a T cell leukemia versus a B cell leukemia, right? That's when you are going to do the panels that I told you about, below 10 and above 10, to ensure, what you are, to ascertain what you're looking at, and so on and so forth. But, the CD45, once you have it, it's going to establish the identity of the tumor you're dealing with. The same exact thing when you have the S100, for example. Of course, that is going to, it's not going to be in place of your morphologic diagnosis. So the most important thing is, in this case, is going to be the morphologic diagnosis. Because if you look at neuroendocrine tumors will have very, peculiar, very specific, kind of morphology. If, let's say, S100 is negative, you don't revert back to not calling it neuroendocrine, because there are some endocrine tumors that will be S100 negative. You see what I'm saying? So those tests are there actually to support your diagnosis, not to negate it. Okay? Anything else? Further.
So regarding paraneoplastic
Paraneoplastic syndrome.
yes, yeah,
Yeah.
the concept behind it.
Right. So actually, this is the tumor mass. Okay. The tumors give rise to metastasis, right?
Yeah.
So the manifestations that you get in paraneoplastic syndromes are not related to the tumor mass itself. Its action on nearby tissue, invasion, destruction, growth, extension into, no. And it is not related to its distant metastasis that it gave rise to. It is related to the making of the tumor cells of usually a hormone-like or a growth factor-like, okay, or actually a substance that is going to have distant effects from the tumor mass. So let's say that the tumor mass is making PTH, the parathyroid hormone, or parathyroid hormone-related peptide. It's going to be making this, but the effect of this peptide is going to be felt away from the tumor mass, correct? It's going to act on the bone, on the osteoclast of the bone. And the result of that is going to be this paraneoplastic, presentation, okay? Let's say that it is making, actually, in the case of a pancreatic cancer, it's making mucin, okay? And this way, the mucin is going to act on the endothelial, actually, layers, resulting in a coagulation abnormalities such as the migratory thrombophlebitis that I mentioned to you. Again, away from the tumor mass and unrelated to the metastasis, okay? It is simply a substance that is being made by those tumor cells that is causing the presentation at hand. All right.
There is
Yes.
some questions from people online.
Further.
Yes. What are tonal filaments?
Tonal filaments. So this is going to be actually showing you hold on a second. Right. So this is going to actually show you that these cells are epithelial in nature, because they are going to be related to it's related to the adhesion of the epithelial cells. Okay. So in a way, actually, it's showing you that those cells are more cohesive than what you see in mesenchymal cells. Okay.
And do they need to know these signs?
No. Again, it is only there actually to tell you that what you are dealing with, to get the concept, which is that those tests that you have seen are related to establishing monoclonality, nothing else. Okay. Yeah.
Doctor, do they have to memorize slide 28?
Okay. Which is what? Which is 28? 28. Again, no. I said that. No, you don't need to do that.
Okay. What are we supposed to focus on in this lecture?
Right. Well, like I think I have talked about this. The first part of the lecture is very important. Everything is important. Let's put it this way. The ones that I want you only to know the concept of is the diagnosis of neoplasia, because this is not really for you. It is for someone who's doing residency in pathology, or who's interested in pathology as a specialty, but not for a medical student. Here, the only thing that I want you need to actually get a feeling of it in a way. Actually, this is one, because you're going to be seeing it in other blocks, as blocks come by your way in medical school. you're going to be dealing with biopsy and frozen section. So here is giving you really the basics. And what I want you to know from these basics is that we're doing all of this work in order to establishing, monoclonality, the type of the tumor, and there are other things that you may get from this testing, including actually the extension of the tumor mass.
Yeah,
That's it. Okay. So this is the first lecture. All right. Let's continue, if you don't mind.